We're all so steeped in our daily grind that it's good to take a step back every once in a while and scan the professional landscape. My guest today has that point of view. He's the VP of content for numerous healthcare business journals, which means he sees a wide variety of challenges and opportunities in our space. And so we're going to pick his brain and see what he sees, and he's going to share it all with us. I'm Carl White, principal at Mark Advisory Group, which is a healthcare marketing agency, and I'm also the host of Practice Care. The mission for both is the same, and that's to help private practices stay private. It's usually what they want, but when it's the providers of care who also own the place, we know that every decision, or we can be very confident that every decision they've got to make about the business side, the clinical side, whatever it is, also keeps patient care top of mind, because guess what they have to go back and do? Take care of patients. So we know it's always going to be in their mind. We can't always say it's top of mind when it's not business owned. That's not a critique. It's just state of affairs. It's just kind of how it works. So let's just try to keep it all privately owned. A lot easier that way. My guest today is Chris Mazzolini. Chris is a vice president of content at MJH Life Sciences. He oversees teams of talented editors who manage healthcare business brands, including medical economics, chief healthcare executive and physician's practice, and the leading veterinary medicine brand, DVM 360. Chris worked as a daily newspaper reporter prior to joining medical economics and has a master's degree from Northwestern University and a bachelor's degree from Kenyon College. Chris, this is awesome. Thanks for coming on.
Yeah, thanks, Carl. I really appreciate it. Thanks for having me.
Yeah, normally we've got somebody who sort of works with doctors day to day or is a doctor themselves, and it's sort of in the trenches. What are you facing? What have you figured out to deal with that? So this is a different perspective for us. So it's going to be neat. That was a brief bio. Anybody who's listened to more than one episode knows this is where we start, but that's what I asked for. So help us get to know you a bit better. Fill in the gaps.
Yeah, so I think that's pretty good start, but probably where I'll go is what I do and what my teams do on a daily basis is we spend time talking to both experts that are out there who are the ones studying what's going on in medicine, what's going on in the business of medicine, or even more importantly, I think, is speaking to those actual physicians and those managers and practice owners who are in the trenches and dealing with all of the challenges that comes with running a medical business right now, whether that's a physician's practice, whether that's running a veterinary practice, which is something I'm taking on now. That's my career in media and journalism has always been about talking to people. So I hope I can be, provide what the vibes are out there really on, how physicians and people who run practices are feeling. And that's really what I spend my days doing and figuring out the best way to create content and strategies to reach them and provide them the information that they need. So
yeah. And listeners, if you haven't, go to medical economics, Google it, physicians, all these chief healthcare executive, physicians practice, just peruse the menu and you will see broad-based, all sorts of different topics. It's not narrow. It's just a good way to, I find myself going there a couple times a month. What's new? What are they talking about? It's just a good way to kind of keep your finger on the pulse. I picture your desk as like piles of, how do you stay? I'm not sure I envy the job. Like, how do you plow through everything that comes in?
So
how do you decide what to publish and what not to publish?
Yeah, so it's funny. It used to be like the desk has become metaphorical.
Right.
I used to be the person with, on both sides of me would be towers of folders and notebooks and things like that. And now it's all my email.
Cigarettes and the whole, the bakers.
Yeah, exactly. And now I have 50,000, unopened emails and those kinds of things. And, hundreds of thousands of opened ones. But yeah, no, really, it's a lot of it is, you rely on your teams to kind of, and the editors who help us kind of run these brands, to kind of filter through and have that news judgment and, what's important and what's not, and to really get to the topics that resonate and that are important to the physicians. And then obviously, like I said before, it's talking to the physicians and finding out from them what they need to know, both, there's what they need to know practically and also what they need to know and hear emotionally as well, which is like a component of it that's, equally as important as, um, knowing this tip to do this and this step to do that. So,
Yeah.
it's sort of a full spectrum thing. But yeah, my metaphorical desk is very, very, very
Yeah.
full. Yeah.
Yeah. I like the last part, especially because when you combine it's lonely at the top with, at least a traditional insurance-based practice, it doesn't get easier every year. Nice
No.
to have a little inspiration every once in a while. So our thank you for that. Our goal is sort of a bird's eye view of what physicians are facing from what you see. And we kind of structured this as challenges and opportunities you see related to, let's start with competition. And these are very, listener, I get it. These are very broad. We'll see. Um, Chris and I talked about these topics, but I don't know what he's going to talk about. So um, let's start with competition.
Yeah. So competition, the way I think about this is, you know, you think about everybody when they think about a medical practice,
Mhm.
you can picture it in your head. And the picture that you have in your head is probably a picture from 30 years ago, right? It's got a waiting room. It might be out of date. It's got old magazines in it. Um, it's you're going to wait there for a long time. And oh, by the way, it also maybe took you 3 months to get this appointment in the first place. Um, Maybe you're going to see your doctor for 9 to 10 minutes. Um, do you have a relationship with that doctor? Hopefully you do, but increasingly, maybe as a patient, you don't. And this is just, I have a sinus infection and I need to see somebody. And so, um, I think in a lot of ways, and then, contrast that with Amazon or some
Mhm.
other sort of consumer service right now, and they're light years apart. And I feel like there's been a effort in the last couple decades to try to say, hey, we can go into healthcare and we can make this sleek, consumer friendly model fit on, what I'll call primary care, right? So those relationship driven
Mhm.
specialties. And there's been a lot of like money thrown at that. A lot of big outfits have gone into it. Amazon's invested in it. Walmart's invested in it, to try to create sort of, these clinics. And honestly, it's sort of fallen off. They have not done well. I think a lot of these big boys have sort of realized, wow, this medical practice thing and these, having these primary care practices, it's a lot of work. It's expensive. There's a lot of administrative burden. And so in some ways, maybe the painting I painted about a practice is like, oh, that sounds kind of derogatory and stuff. But in a lot of ways, it's like that for a reason, and it's like that for reasons that have nothing to do with the physicians, the people who run those practices, or the patients. That medicine is and healthcare in our country is a giant behemoth that is impossible to change and turn. And so I kind of prefaced, competition in that um, practices and physicians today are dealing with a ton of different potential competitors, right? Like I've mentioned, these other larger kind of chains, they're hospital owned practices. Maybe it was an independent practice that sold to a hospital, and now they're a competitor. A convenient clinic at a Walgreens or something like that. But like the traditional kind of old-fashioned, boring fee-for-service practice that maybe has a little bit of value models. It's 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 not going to go anywhere. So that I think is like sort of the beginnings, I would say, about my thoughts on competition. Not that physicians and practices can't do things to make themselves more patient friendly, more consumer friendly. I guess I'll use that
Yeah.
term. Um, because there are things, right? But I do think that there's a lot of things about traditional medicine that are sort of stuck for a lot of external factors.
Yeah.
And then the other thing we could get into, I won't drone on more about it now, is sort of like the status of independent practice, which I think you and me are both very interested in as well.
hmm Yeah, I've seen a couple, just to stay primary care as an example. It is at its core a relationship type of practice. And I've seen a few. There's one in down. I'm in Chicagoland, so downtown Chicago. I saw it was tech focused. Where the tech leading, and I just went, it's great. Who cares? I mean, but and they're not doing very well. And it just seems like they were trying to make what is a relationship business, to speak very, very generically, transactional instead. I don't know if they intended to do that, but that's what they did. And so part of the reason a primary care practice or any flavor of it has a bit of a better chance is because patients come back and you don't need to attract as many. Anyway, that's what they were sort of, I don't know if they realized what they were doing, but they did. And you sort of open the door, like the high level state of private practice.
Mhm.
Talk about what you see there. It's challenges, and I get these are such broad questions, but
Yeah.
we're taking sort of the bird's eye view, and that's what that means. So yeah, what are you seeing?
Yeah. So I think there's both challenges and opportunities when it comes to independent practice right now.
Mhm.
Obviously, like, and we can talk about this for hours. So I'm gonna
Yeah.
try not to go too nuts on this. A lot, obviously, there's there's external forces in terms of the market that are
Mhm.
driving physicians towards um, employment away from ownership. Is, I
Mhm.
guess, a broad way of explaining it, where um, you know it's harder and harder to run a practice independently because of administrative burdens. You know, all the different value-based payment models from all the different payers are harder and harder to administrate. So you need good staffers, which are harder to find. Reimbursement rates have been declining and not keeping up. I shouldn't say, I guess what I should say is reimbursement rates have not been keeping up with costs, right?
Yes.
For decades. I mean, there's a famous chart with the AMA where you see, I think anyone in medicine can like visualize that chart. And so it's a huge problem. So sometimes you're a physician and you can say, hey, I can sell my independent practice to the hospital
Mhm.
or to increasingly a private equity outfit and, get a nice nest egg and, not have to worry about all this business junk.
Mhm.
Um, the other side of it is increasingly younger doctors coming out of med school are less interested in running their own business.
Hmm.
It's not something that um, and maybe this is something I've always been curious if this is something that will change as they get older. There's always the old saw that people become more conservative as they get older. But like I would say in general, medicine has become a more I would say younger physicians are interested in patient advocacy and come out of medical school wanting their own life, wanting that work-life balance, and wanting to do things that they see as giving back to the community.
Which just makes
And
me wonder, are they
yeah,
seeing the landscape today and saying to themselves, why would I ever do that?
yeah, I think so.
Like, you know,
I think that's a lot of it. And I
why
think
would I
maybe
work
the
more than 24 hours a day to make less next year?
yeah, exactly. And
Yeah.
I think, the exceptions are, there are physicians who, right, own their own practices and then maybe their children go into medicine and inherit that practice. But like, do they really want to do that?
Mhm.
Right. So I think those two forces, right, that kind of like the external challenges of the business of medicine that are pushing practices and then younger generations coming into medicine
Mhm.
much prefer an employment arrangement where they can work 40 hours contractual plus often get money towards paying their medical student loans
Yeah, and
which
there's
can be
that.
considerable,
Yeah.
right? So those are the two kind of different things. I would say one of the interesting trends, and when I say trends, I don't want to overstate this as if like you know 30% or like
Yeah,
a third
yeah,
of
yeah.
all
I know trend.
physicians.
I get it. Trend has
But
got to be caveated.
yeah,
Yes.
but membership medicine is something that a ton of physicians are interested in. When I say membership medicine, I'm talking about either direct primary care,
Yeah.
direct pay of some kind, or even, what you call concierge medicine.
Hmm.
It is a way that we're increasingly hearing from physicians as a way to have that independence, right? Where, instead of seeing 25 patients a day, you might, and, for 8 minutes or something, plus all that charting you have to do at 8 p.m. at night when you'd rather be spending time with your family, right? You can see 6 or 7 patients in a day. Talk to that patient for an hour, right? Yeah, they have your cell phone that they can reach out to you at 10 p.m. But we talk to these physicians who do this, and they to a physician say patients never abuse that privilege. And so there is this kind of narrow lane for those physicians who say, gosh, I don't want to run a business that's like in this traditional fee for service kind of quagmire, but I also don't want to be like a number employee in this giant health system where I have to sign some non-compete, where I'm going to have to like move out of my town if I want to like open my own practice, right? Like, so I need something that can like preserve my independent spirit as a physician. But those two options don't appeal to me. That like sort of DPC, direct pay, membership medicine model seems to be a growing interest among doctors, both newer doctors coming out or, I would say like those mid-career physicians who are like young enough that they're not like, I'm about getting close to retirement, I'm just going to stick it out, right? That are interested in transitioning to that. And so I do expect that those kind of models to increase interest. Now, they come with challenges for the greater health system, because one of the secrets is, if you're going to have a model like that, a physician that had 2,000, 3,000 patients on their panel suddenly has 300 to 500 patients on their panel.
Which is what they want.
Yes, which is what the physician wants, right?
Yeah.
But if you have too many physicians doing that, you end up having an access issue. So, but speaking from the physician standpoint, it's like a realistic potential opportunity to find that kind of that slice of independence in a profession now where it feels like independence is going extinct.
Yeah. Couple thoughts. One is, we have a client that does direct primary care. She's the happiest. It's like a cause. She's great. If I lived close enough to her, we'd be talking about a trade for services, because, every one of her annual appointments is 90 minutes, even if you've been a patient for 15 years. If I get 8 minutes, and it just checks all the boxes, because you want to take care of patients the way you want to take care of them, but you can't do it in 9 minutes.
Yeah.
If a patient walks in with a question that has even a teensiest layer of, I'm not sure yet, I need to check, can't do it in 9 minutes, right? That's not the way they were trained. The other side of it is just, listener, just kind of be cautious. I do hear every once in a while of the membership model trying to be applied to specialties where access really isn't that much of an issue. So the reason it works in primary care is because what I just said. It's frontline care. It's hard to diagnose in 9 minutes. It's getting harder for whatever reason. I have a theory, but we're not going to go into it. Direct primary care physicians are not paid like they should be compared to what specialists get, which is too bad, because if primary care is working well, people are healthier because you're catching things sooner, but I don't know why. So anyway,
sorry to interrupt, but we could go for an hour on, that like, we talk to a ton of primary care physicians, and you can make a very solid argument that, from the physician perspective, that the biggest flaw in our healthcare system is that primary care physicians, relationship-based primary care, so everything from family medicine, internal medicine, pediatrics, obgyn, cardiology, you can make an argument for, right? These relationship-based ones, that if you flipped the script and you paid those physicians the higher salaries and have the procedure-based physicians making lower, like these are the quarterbacks of the healthcare system, is what everyone always says. The quarterbacks of the healthcare system, they're the ones who, are the masters of preventive medicine. They're the ones who get our healthcare system. It would solve the physician shortage, because more physicians would want to be in primary medicine. And, obviously, I'm sure you could poke a million holes into a lot of these things. You need oncologists, you need surgeons, right? But I do think that that they make a good argument that primary care is undervalued in the US healthcare system, and that it's just one component of, kind of a creaky system, and why, it doesn't work
Yeah. You
in
could
some
even pay
ways.
the specialist the same, but if primary care is
Yeah.
working, then it's logical to say that, for every 10 patients today who have to go to, I don't know, an interventional cardiologist,
Yeah.
um, because the problem persisted. Maybe it's five if primary care is able to do the job every primary care doctor really wants to do,
Yeah.
you know? So yeah, but yeah, the membership models, just be careful, right? Because the reason membership works for primary care is because they can't do the job they want to do and they're being asked to do when insurance pays.
And you have to, there's
Like once
obviously
I heard of a pediatrics practice, and it wasn't anybody I knew, it was sort of secondhand, and it was, yeah, they want to do a DPC for pediatrics, and my first thought was, we never had a hard time getting into our pediatrician, and they're traditional. So,
that's,
good for you. But listen, unless the unmet need is there, Dr. X, who's thinking about this, it's not going to work. The
look,
unmet need must be there.
when we cover this, cover these membership models at Medical Economics and at Physicians Practice, probably are two brands that do this
Mhm.
the most. Like the couple pieces of advice that we always that physicians and experts in this always provide, that I think I would kind of pass along, is always talk to your colleagues that, or people out there in your market who have
Mhm.
done this,
Mhm.
right? To know, like, what challenges are you not thinking of, right? Because there's
Yeah.
always things that come up.
Yeah.
And so you always want to talk to people who have gone through this.
Mhm.
And you always want to, like, do the research first. Like, you don't want to jump in. Like, you know, I don't want to make the comparison. It's like, opening that restaurant in that location where the restaurants always go out of business. Every town has one of those, but
Mhm.
like, you don't want to make an
But
emotional decision
yes,
here, right?
correct. Correct.
So it's like, you want to talk to people that have done this, especially like if you're a primary care physician, the DPC movement, there are so many doctors out there in the country who would love to talk to people about that, tell them all the pitfalls, tell them where to go first, what to do next, like, reach out to people. Don't
There's
do it in a vacuum on
organizations,
your
there's
own.
annual
Yeah.
conferences, they're
Yeah,
out there. Yeah, absolutely.
exactly. So
Absolutely. Yeah. Um, the last thing I'll say on this is that if you're going to go membership, um, the business model of I'm traditional and I'm going to shrink down to membership seems to be more approachable than I'm going to start, evergreen, no pay. Both are doable. It's just a different, I guess, kind of, it's a different business model. It's not a different business. It's a different startup model.
yeah,
So just
totally.
be eyes wide open about that.
Totally
Okay.
agree. Like, it's two different things. It's apples and
Yeah.
oranges in some ways.
Yeah.
So, what I'd add is, if you're going to do one of them, is talk to people who have done it
Correct.
that way. Yeah.
Yes. 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 Okay. Let's move on. So we hit a lot about trends and competition. Can't get out of an episode without talking about AI. So challenges and opportunities you see from your vantage point in private practice for AI, with AI.
Yeah. So AI is very interesting because, in general, I think it's interesting because most physicians and practices, I think, are using it in some way. But every now and then you run into a physician and they're like, I've never touched it. And it sort of gives me like a double take, right? But I think in general, most I was doing a little kind of digging around, and just to kind of like, where are we at now? And it seems like about two-thirds up to three-quarters of physicians have said they've used AI in their practice. So I think we're getting up to a pretty high level of people who actually use it for a work-related thing and not just asking ChatGPT to,
Okay.
come up with something random,
Right.
right?
Right. Right.
And um, and they're using it to help with documentation. They're using
Mhm.
it to help with, like, emails, like a lot of, like, just clerical work. I think a lot of the same way that we're all using it, with the
Mhm.
added burden that, a lot of this stuff you have to make sure you're careful about HIPAA and about
Mhm.
confidentiality and all that thing. So, but when to go back to AI in general, I would say when we talk to physicians, the one thing head and shoulders above all else are the AI scribes. The AI scribes they love. Um,
This is taking notes during an appointment.
Yeah, exactly.
Okay.
And, it's increasingly you're going to the doctor and they're saying, hey, I'm using this AI scribing tool. Do you mind if we have it record this while we're chatting? And um, I don't think anyone's going to be going to an appointment for much longer if they are already and not kind of get asked that from a doctor. Um, and what this is enabling them to do is, you know, eliminate that pajama time that a lot of doctors call it, where they're doing their charting at night, either after the family's gone to bed or while they're trying to eat dinner, because they're jammed in patients all day and then they're charting at night.
And absent anything else, as awful as that sounds over time, what are the odds that you perfectly remember
Yeah,
all 25 appointments from 6 hours ago? Like charting is detail, right? I mean, so
ex-
yeah, yeah,
exactly. So
yeah.
that I think is like number one. The thing that when we talk to physicians, the thing that has saved them the most time, that has been the biggest stress reliever. And there's obviously a ton of different tools out there,
Mhm.
some of which I think are kind of bundled with EHRs or practice management software and things like that.
Mhm.
Um, but those are a huge thing. Obviously, they're using LLMs. More and more, you're hearing about open evidence, which has obviously open evidence has been around for a long time, but they now have their own LLM that's like tied in with various medical journals.
Hmm.
I think New England Journal of Medicine has a big agreement with open evidence, where it's basically a way for a physician to, you know, query like clinical questions, right?
Mhm.
And so like there's been a lot of coverage out there recently about sort of how physicians are using that. So I
Yeah.
would say those are sort of like the main things. And sort of kind of an interesting one that I've encountered enough to be like to note that it's, a thing that's out there is kind of modeling out difficult conversations with patients.
Oh,
So,
interesting.
yeah, whether it's a difficult diagnosis or something like that,
So
or
AI plays the role of the patient.
yeah, exactly. So,
Interesting.
yeah, you have to talk to somebody about their weight. Those are kind of hard conversations where you kind of try out some things and kind of practice, which I find very interesting. But I've encountered that enough that it's, that I thought it was worth mentioning.
Yeah. Two just points to emphasize. You said, a lot of EHRs or practice management systems have some of these things. It's a great place to start. Why not start with something you're already using? Chances are, let's hope that the EMR system, you've just recorded notes with patient X, it just gets it right into patient X's file, which is where you want it anyway, right? There's nothing to integrate. There's no bridge to build. Try that. Um, and then I love the idea of playing the difficult conversation. That's great. I mean, I hadn't thought of that one. And because we all you're so damn busy. It's you want to be empathetic, you want to be in the moment. It's just a little practice. You run a practice. You're practicing things
Yes.
forever. So don't gloss over. Particularly if you're, well, I don't know, just be honest. I think that's really cool.
Yeah, definitely. I was like, oh, that's very interesting. So yeah.
Yeah. Yeah.
Um, and in terms of like quickly, like in terms of worries, I would say their biggest worry is using AI going to get me in trouble? Whether that's um contribute to a diagnostic error, contribute to something that could result in like a malpractice lawsuit or
Yeah.
a board complaint or something like that. There's really no case law to the best of my most recent coverage. There's not a ton of case law out there yet on any kind of malpractice or anything like that involving AI, but I'm assuming we're going to be heading that way at some point. We actually had a cover story in medical economics late last year. The actual month is escaping me, where we talked to uh, experts on sort of AI's impact on malpractice, and I can send you a link you could put in the show notes if you'd
Yeah,
like.
that's great. Any big takeaways from that? I'm
Yeah,
curious.
basically that like this is uncharted ground at this point, and that you know no clinician should sort of cede any decision-making authority to any kind of AI tools, which,
Hmm.
sounds obvious, but, in the busyness of the profession, things happen. The other thing being that where, maybe it becomes a bit muddier is if you are a physician in one of those employed situations and, there's an AI tool that you did not make the decision to
Mm.
procure, right? It's a tool that is thrust upon you by your organization. Where does that come in? And something goes wrong because of that AI tool. Where does that come in? Right.
Mm. Interesting.
So there's a lot of uncertainty right now. And, as always, never think using software is going to get you out of trouble.
Correct.
You know?
Indemnification and AI.
Yeah.
Interesting.
Yeah.
Interesting. Um, I want to go to staffing kind of
Mhm.
as a final topic. We had other ones, but this one I think is interesting. Challenges and opportunities. Um, it's not getting any easier. Uh, what are you seeing?
Yeah. I think when it comes to staffing, nobody wants to hear about this anymore, but
It's true.
COVID-19 unlocked, like unsealed something, right? Like nothing, when I think for practices, nothing's quite been the same since then. I think that the biggest challenges for, and if we focus specifically on private practices,
Yeah,
right? The
yeah.
biggest challenges are on finding and hiring great people and
Hmm.
then being able to retain those people.
Hmm.
Because, you maybe can't offer the benefits, you maybe can't offer the salary that the hospital can, right? So that's a huge challenge. And, traditionally, private practices often, think about like the stereotypical small practice, you know, where the physician might be, a man in a small town and the administrator is his wife, right? That is like the old school thing. It's not like that so much anymore. So that means you need to find people to fill these roles. You need to find people to um, work the front desk. You need to find people to do your billing. You need to find people to do your coding. You need to find nurses. You need to find all these people. And, so you end up, staffing becomes frankly one of the things that leads to, can I keep this practice independent or should I just, go to talk to the hospital about
Yeah,
seeing
yeah,
joining. So that's the biggest thing is retaining those A players, right?
yeah,
Keep hiring and keeping those A players.
yeah.
Um, and I think from the clinician side, a lot of older practice owners are looking for those younger partners, right, to sort of keep the practice going after, and because they're thinking about their exit strategy,
Hmm.
and um, so so I think there are those opportunities to circle back to the beginning
Hmm.
for physicians who want to have an independent practice. I think there are some of those opportunities out there in certain markets to maybe join a practice and maybe get that ownership stake as an older physician is maybe looking to retire.
Yeah.
Um, but I would say those are the biggest challenges when it comes to staffing right now.
And I hear anecdotes, not too often, but I wanted to ask you about it. Physician sells the practice, goes, into the hospital, gets frustrated for different reasons, wants to come back out and does so. Do you see much of that from your point of view, from where you sit? Or
Not a ton, like anecdotes. I would say
yeah,
the same. We hear anecdotes,
we're not to the
but
level of trend. Yeah.
yeah. And the thing we always hear about are, the non-competes and the geographic restrictions, right?
Mm,
That you go into that hospital, you're most likely, going to be signing some of those documents. And so then getting back out, you can get back out, right? You can not renew your contract, you can do whatever, but like then can you reestablish a practice? Do you have to move within whatever geographic restriction
yeah.
outside, right? So that is the issue we've heard is that, and I think it contributes to some of those feelings of burnout and thing is feeling trapped, right? You've gone into sort of employed medicine and then you feel like you can't get back out.
Yeah. The other thing that this is definitely trendworthy, maybe larger, is just kind of rethinking about what do you need people in the actual physical office for? And at a
Yes.
minimum, you need them for anything that's patient facing, but all the rest of it, like insurance verification, there's all sorts of administrative important stuff that never, is patient facing. I can't go a week without some medical VA company of one kind or another. I get email. I'm not even in the, so um, they're out there, they're growing. They've seemingly figured out, how to sound pleasant, how to sound US, HIPAA, fraction of the cost. There's a lot of these places that have worked it out, and I think it's time. I mean, why do you need somebody sitting in your office on hold with Blue Cross about verification or a billing dispute? Always. Why? It's time. And the people who talk to enough practice owners, I hear it enough where I go, it's here. It's here. I mean, it's here. Um, and so, why pay somebody $25 an hour for a $10 task? Start
Yeah.
rethinking about these repetitive, must get done, but so that the people you really focus on are those who are dealing with patients, one with front desk, in the office, with pay, whatever. But are you that's it just seems like it's here.
It is. And I think,
And I even feel out of date when I say it seems like it's here. It's here.
yeah, it's here. And
Yeah.
I think one of the challenges sometimes though is you have these practices where the physician owner is also the office administrator, CEO, whatever you want to call it, right? Where because yes, they can then get those contracts to do all that work with third parties and stuff, but then you have to manage all that stuff on top
Mhm.
of seeing patients. And I think those practices that have that split where maybe the physician owns the practice, but they have that practice manager, right? Who is a professional at managing that business, who
Mhm.
can run, who can manage those contracts and
Mhm.
figure out what can be outsourced and we need a person here,
Mhm.
like is 100% valuable.
Yeah.
So that's, I think the thing is it just becomes, because like, the physician is sitting there thinking like, I got 25 payer contracts and they're all different. And then I got, oh yeah, I got the EHR contract. I got the billing contract. I got all these contracts, the patient portal, and it's just like, oh yeah. And I got to see 25 patients. Right. So that's part of the
Well,
burden, I
what's
think.
funny about that, and this is so easy for me to say, I'm sitting in the back in the cheap seats, and the doctor's
Yeah.
up
Yeah.
on
Me
stage, and
too.
I'm in the
Me too.
studio
Yeah.
audience. But the only person in what that scenario you just described who doesn't know how to figure out how to make it work is the physician, him or herself.
Yeah.
These companies do, they know. Well, you'd ask them, but they know insurance really, really well. It's a puzzle. It's a puzzle. It's a pain in the ass puzzle, but doesn't mean you need a US based citizen who sits in your office to be the only one who can figure it out,
Yeah.
you
And
know?
I think part of it is because the, you know, physicians aren't taught business in medical school. And the physicians who are also business people, it's a unique combination.
Mhm.
And I think that in the old days, you could be a physician without real business acumen
Mhm.
and survive and
Mhm.
thrive
Mhm.
because, you would build a practice.
Build it, they will come. There wasn't a
The
huge amount of
patients in your
competition. It was
community, they're going
simple.
to, yep,
Yeah.
they're going to come. Now I think you need to be a real business person
Mhm.
to do this stuff. And the skills and intelligence, which obviously, is considerable to be a physician, all that clinical knowledge, all that stuff is it's not necessarily the same thing as running a business. And I think the challenges of our healthcare market now really kind of can put that into perspective, right?
Yeah.
It makes it very apparent.
Yeah.
Um, which leads to I don't want to run my practice or I need to sell this practice.
Right. 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 Um, so we covered a lot of ground, and it's such a broad topic.
Yeah.
Um, with that though, is there anything you think we should have hit on in the sort of the depth and context we've been living on, but we just didn't get to? And it could be a yes or a no.
I would say that um Nothing's coming to mind. I think
Yeah,
I mean, nothing that's not going to open up another giant ball of worms
right,
and a topic that would blossom into a million other topics. I think
right,
we covered a lot of ground.
right. And for the topics that we did talk about, um, the context of this final question is we've caught a listener's attention. They say, you know what, that guest was right. I want to start doing what they've been talking about, but they just don't know where to get started. Um, this episode's a bit different, but even though, I mean, is there anything you think about the things that we talked about where somebody could say, just do one thing to kind of get so you could pick one and say, if you're thinking about this, start here. Like I'm thinking of if you're looking at your staffing and your over your overhead, saying something's got to give. Google medical VAs and just, you know what, set up some chats, set up some, this is what I'm thinking.
Yeah.
Start getting smarter on it.
Yeah,
That's what I would say.
100%. The other thing I would say is like whatever you've thought of to run your practice better,
Mhm.
somebody else has not only thought about it, but is doing it.
Mhm.
Like, don't, don't, especially if it's easy to feel like you're living, like you're on an island and you're by yourself. There are millions, hundreds, millions. There are thousands, hundreds and thousands and hundreds of thousands of
Mhm.
physicians out there who are kind of dealing with the things that you're dealing with.
Mhm.
And that, you know, reach out to people in your specialty, your medical societies, your communities. You go to conferences. I know it's like the conferences took like a hit, right, with like the pandemic, but get
They're
back
back.
out there and talk to
Yeah.
people. And anything that you can think of, somebody's out there and trying it, and you can talk to them about it.
Yeah.
So don't feel like you're on an island. Like go to, go and talk. And in the meantime, um, check out medicaleconomics.com, check out
Mhm.
physicianspractice.com, because we're talking to a lot of those people, and maybe there's somebody that we've interviewed on our podcast or on a video that could be somebody that you can reach out to get some advice. So
Yeah.
as that's an intermediate step, that's a self-serving intermediate step, but in
Yeah.
all seriousness, go out there and talk to your colleagues.
Yeah. And I'll just add, as a business owner also, pick one pain point you've got and just focus on that. Because you don't know what you don't know, and you're going to ask more questions before you start to figure things out. Um, just pick one and get going, and you'll make more progress. You get to a point faster of you'll figure out I can do something about this, or I realized I can't. Whatever it is, you'll bring it to finality, and then you can figure out what to do. Cool.
Totally agree with that. Yeah.
Yeah. Chris Mazzolini, thanks for coming on Practice Care. This is really interesting and a different take.
Thanks, Carl. I appreciate it.
Yeah, and we've got contact information for you that'll go into the show notes of your episode. So anybody who wants to get a hold of Chris and find out more about him, you've got that way to do so as well. Couple points before wrapping up. First, if you are a private practice owner, or you're someone like me or someone like Chris that serves private practice owners in one way or another, there's chances are that you've figured out something on the business side of private practice that your peers would benefit from. And don't overthink what that is. If you thought, it could be something simple, something hard, chances are something you've figured out is something that you would think nobody else would be interested in. You're wrong. Lots of other people, just like Chris said, people are, struggling on all sorts of things. Come on Practice Care and tell the world about it. In the show notes of every episode, there's a link, couple of clicks. It'll take you a minute. Tell us what's on your mind, and we'll get you scheduled as soon as possible. And finally, subscribe to Practice Care. It's one word. If you haven't done it yet, shame on you. We're everywhere, easy to find, easy to subscribe to. We drop a new episode every week, and that's the easiest way to stay up to date with them. Thanks very much, and until next time.